Part 2, we're going to look at drugs that lower cholesterol and triglycerides, and then the lifestyle management program that makes sense around those things. So the drugs that lower cholesterol and triglycerides in people that have hyperlipidemia are the statin drugs, they're bile acid sequestrants, fibric acid derivatives, and high doses of the B vitamin, vitamin B3, known as niacin, but at pharmacologic doses. So to review for you what happens again, and I taught this to you last year, so this should be a review, that when you eat foods that are high in saturated fat, trans fats, fried foods, that those foods get absorbed in the chylomicron in the gut, and they travel through the lymphatic system. They will eventually, in most cases, within the chylomicron, get dumped into the liver. And so this is, let's say this is a liver cell, this great big box here. And when the saturated fat, or those kinds of fats are in the liver, it poses a problem because the liver can't just send those fats out into the bloodstream because, you know, water and fat don't mix. Oil and water don't mix, right? So fat doesn't dissolve in the water medium of the bloodstream because it's a nonpolar particle, can't dissolve. So the liver has to package the fat in what's known as a lipoprotein. So it actually makes this little egg-looking thing here known as the very low-density lipoprotein. And it puts the saturated fat in the center of it bound to glycerol. So you form triglycerides, right? 3 fatty acid chains attached to the glycerol backbone. You have the triglycerides in the center of the egg, say where the yolk would be. And then the shell of the very low-density lipoprotein is made out of protein. It's a protein shell. Why is protein on the outside? Because protein dissolves in water. So it'll be able to transport the fat because protein can dissolve and drag the fat with it. Then in the intermediate zone here, inside, you have phospholipids and you have cholesterol. And this is the big step. So when a person eats those kinds of bad fats, saturated fat, trans fats, a lot of fried foods, when those fats arrive in the liver has no choice but to turn on cholesterol production. And when you turn on cholesterol production now, you're turning it on to put the cholesterol into this intermediate zone. Now the very low density lipoprotein floats out into the bloodstream. And the fat cells are interested in storing the fat. So pay attention here. In the endothelial lining around fat cells, those endothelial cells will secrete a very important enzyme. It's known as lipoprotein lipase, or LPL. Lipoprotein lipase will hydrolyze the fat in the very low density lipoprotein, allowing the fat to move into the fat cell, and then it gets converted back into a triglyceride again. And so you remove the fat from the VLDL with the help of lipoprotein lipase. What if you're born and you have an inborn error of metabolism where you can't make lipoprotein lipase? Some people don't make lipoprotein lipase. What kind of blood picture am I going to see in that person? They're going to have very, very high triglyceride levels, and their cholesterol will be modestly elevated, but their triglyceride levels will be sky high. But normally you can clear the fat, and then what you're left with now is a remnant particle where the fat's been removed, but the cholesterol is still there. And that remnant particle from the very low density lipoprotein is now known as the low density lipoprotein, the LDL cholesterol particle. This is the one that's most atherogenic. Notice also that muscle cells, skeletal muscle, cardiac muscle, and smooth muscle, can also take the fat out of the VLDL with the help of lipoprotein lipase, and it can take the fat into the muscle, and through beta oxidation, muscles love to burn fat. So they can burn fat. The fat that you had at your most recent meal, your muscles are burning that fat. They're saving their glycogen stores in case you need to sprint away from a predator and you have to run really, really fast. You do that using anaerobic metabolism. You can burn your glucose down anaerobically and get lots of power for sprinting. So muscles are saving their glycogen in case there's more high-intensity activity required. They burn fat in a steady state. The more lean mass you have, the faster is the rate at which you burn fat. So when you do weight training and you increase your lean mass on your body, your metabolism is fast. Your fat burning capability is greater even when you're just sitting in a chair. So the fat can be taken out by the fat cells and by muscle. And the remnant particle is known as the LDL cholesterol particle. Where does it go? Remember that all the cells on your body have these receptors. And the LDL cholesterol fits right into the receptor, and through what's called receptor-mediated endocytosis, the receptor grabs the whole LDL cholesterol particle and pulls it in. And once it's inside the cell, lysosomal enzymes will blow it apart, and then the cholesterol can be used to make certain components of the cell membrane. Remember that in your testicles, in your ovaries, in your adrenal glands, that cholesterol becomes the building block from which your body makes testosterone, estrogen, progesterone, cortisol, aldosterone. All of these steroidal hormones are made from cholesterol that primarily got to the cell via LDL. You go, well, obviously you need some. Yes, you need some, but you don't need lots. Some of that cholesterol, when it gets picked up by the liver again, will be converted into bile acids. Pay attention here. You have a meal that has some fat. The liver and gallbladder secrete bile acids to emulsify the fat. And a lot of the bile acids recirculate back to the liver and can actually become cholesterol, or they can remain as bile acids. But what if, while the bile acids were in the intestinal tract, and there was a bile acid magnet that could cling to the bile acids, so they can't be reabsorbed through the enterohepatic system. They can't get reabsorbed back into the body. And when you have a bowel movement, basically they're leaving your body. There are drugs called bile acid sequestrants that we're going to see. They grab that bile, and when you defecate, the bile leaves your body. So now the liver says, oh my God, I don't have enough bile for the next meal. So it increases the number of LDL receptors. It pulls more cholesterol out of the bloodstream to make more bile, because it's going to need it. So you can lower the blood cholesterol by getting the liver to pull more of the LDL out of the circulation by dragging more bile acids out of your body. How else can you drag more bile acids out of your body? Anybody? What kind of fiber? Soluble dietary fiber, because you're right, does exactly the same thing. When you have beans and peas and oats and ground flaxseed, apples, peaches, pears, and plums with all that pectin fiber. Tell me when your birthday comes. That psyllium husk fiber, the chia grain. This type of fiber are also bile acid sequestrants, and they can help to lower cholesterol. The point is that some of the cholesterol becomes bile acids. Under your skin, when sunlight hits your skin, don't you make vitamin D? You make it from 7-dehydrocholesterol. So you're going, well, I guess I need some cholesterol. Yes, but once the cells of the body have all the cholesterol they need, what they do is they shut these doors. They no longer make these LDL receptors, so no more LDL cholesterol can get in. And so if you've made more LDL particles than the cells need, the extra LDL stays in the circulation and will circulate through your blood vessels for 3 to 5 days. And where there's been injury to the artery wall, especially where there's bifurcations, where vessels split into two and there's more turbulence, that cholesterol tends to stick to the walls of the artery, gets picked up by the macrophages, and they become foam cells, and you start to form atherosclerotic plaque. And that's how your arteries narrow. LDL builds up in the blood vessel wall, the arteries narrow a little bit more, a little bit more. By the time when you get to 85% narrowing, you end up with angina, sudden death heart attack, non-fatal heart attacks, you have a stroke, you start to have Berger's disease, intermittent claudication, your kidneys shut down, now you need dialysis because you can't filter blood anymore, and you got all this plaque built up in your system. It builds up slowly over a person's lifetime. And also remember this, about 5% of the population is born where genetically they can't even make LDL receptors. Imagine if you couldn't make any LDL receptors. You know how high your cholesterol would be because you can't clear it from the bloodstream? Sky high. Those people need drugs. Most people just need to manage their diet and lifestyle better to keep their cholesterol levels under control. The HDL is the good cholesterol. The liver makes, and this is an exam question always, the liver makes HDL as a totally separate entity. It's not a remnant particle of the LDL. It makes it as a totally separate entity. The HDL, we think, goes into the circulation and pulls the cholesterol plaque out of the artery wall, brings it back to the liver, and so it reverses atherosclerosis. You raise HDL levels through aerobic exercise. If a person has extra body fat, as they become thinner, as their body fat shrinks, the HDL goes up. And premenopausal women, because they have more estrogen, tend to have higher HDL levels. And that seems to help protect them up to the time that they go into the menopausal years. So a high total cholesterol to HDL ratio is not a good thing. When we talk about the total cholesterol in your circulation, we're saying how much cholesterol, if we add it all up, is in the VLDL and the LDL and the chylomicron and everything in between, plus the HDL, that's the total cholesterol. And then of all that, if we take the total cholesterol and we compare it to the amount that's in the HDL, if you have really very little HDL and you have your total cholesterol is high, that's bad. It means a lot of the cholesterol is in the LDL and all the things that cause atherosclerosis. If the total cholesterol to HDL ratio is better, if the HDL levels are high and your total cholesterol is low, and you've got a 3-to-1 ratio or a 2-to-1 ratio, your risk of having a heart attack or a vascular event is much, much lower. So that's the total cholesterol to HDL ratio. We're going to come back and revisit that. So when cholesterol is high for 90 to 95% of people, it's primarily because they're eating a diet that either has already too much cholesterol in it, or more often because they're eating foods that are loaded with the fats to turn on cholesterol synthesis. And in certain cases, when they're eating too many sweet and sugary things, the liver will convert the extra sugars, of course, also into fat, some of that into saturated fat, and we'll have to make VLDLs to transport that fat as well. So cholesterol synthesis turns on as well to a lesser degree when you have too many refined sugars or just too many carbohydrates in general, even from starchy ones. But the cholesterol raising effect is greater from eating bad fats than it is from eating jelly beans, jujubes, and gummy bears, to be quite honest with you. They pose other problems in terms of insulin problems, but in terms of atherosclerosis, the fat story outweighs the hyperglycemic story to some degree, although both things need to be working properly. My point is that a medical doctor is trained today, when they see cholesterol levels that are elevated, to put the person on a drug that will block cholesterol synthesis in the liver. If the liver is about to make cholesterol, if I can say, no, I'm going to block the step so you can't do that, then cholesterol levels won't rise so much. I can bring cholesterol levels down. But if I do that, then I'm sort of not allowing the fat to get out of the liver cell the way it was designed to. Is that correct? Still following the story? So now fat is going to accumulate in my liver cell because I can't effectively transport it out without making that cholesterol at the levels that my body's designed for. And so when a person's on a statin drug, the risk is that fat builds up in the liver cell and it damages the liver cell. And so when you're on drugs like that, you need to have your blood work done on some level of frequency to make sure that liver enzymes are not leaking into the bloodstream, which would be a sign that you're damaging your liver. So right away that tells you, in my view, that this would not be the first thing I'd want to do to bring my cholesterol down. Putting my liver cells at risk for damage when I could be lowering it in other ways. And so what statin drugs do is they inhibit the HMG-CoA reductase enzyme. I'd expect you to know that for exam purposes. And when you do that, you're also inhibiting CoQ10 synthesis. We'll talk about that because if a person's on a statin drug, they should also be on CoQ10 to compensate for the CoQ10 they're not making anymore. These are the side effects of statin drugs. In up to 30% of users, they get muscle pain, like deep muscle aches. So if I'm a chiropractor, I want to know that because this is one of the top-selling drugs in the world. Lipitor, Crestor, these statin drugs are very commonly used. People end up with muscle pain. They come to see you when, in fact, it's an adverse reaction to the drug. You need to keep your eyes open for that. Liver damage can occur. This person should be having their liver enzymes checked at least every 3 to 6 months in the early going for sure. And then there's other things, impotence, fatigue, fever, flu-like symptoms. The thing that happened, they took certain statin drugs off the market a few years ago because they were causing rhabdomyolysis, where the muscle protein would break down, chunks of muscle protein would float into the bloodstream and then clog up the kidney tubules, the filtration part, and all of a sudden the person would go into sudden and severe acute kidney failure. And some people have died. The thinking is that the rhabdomyolysis occurs, the muscle breakdown occurs because of the CoQ10 deficiency that's imposed by the statin drug. Without enough CoQ10, muscle function is lost and muscle tissues break down. We think that some of the muscle aches that are induced by statin drugs can be reduced by giving the person coenzyme Q10 with the drug. Anyway, some of that remains to be seen. Here's how the liver makes that cholesterol. It makes it from acetyl coenzyme A. It's a multi-step process. You notice that the drugs inhibit HMG-CoA reductase. So statin drugs are HMG-CoA reductase inhibitors. You follow? And this is also a main pathway through which the body makes CoQ10, also known as ubiquinone. So when I'm blocking this pathway, I'm also blocking the synthesis of some of my coenzyme Q10. So even on the packaging information, doctors are told if you're going to put a patient on a drug like this, they should be getting at least 90 to 100 milligrams of CoQ10 to maintain the CoQ10 levels. Otherwise, the person might go into congestive heart failure. Some studies in the United States have shown that since the introduction of statin drugs, the incidence of congestive heart failure has actually increased in the United States. We think because we're causing CoQ10 deficiency with the drugs. So I'm not saying that no one should ever go on a statin drug. I'm saying if they're on a statin drug, you might want to point out the necessity of being on CoQ10 as a concurrent strategy. Statin drugs are used by this was dating back to 2006, 13 million Americans, another 12 million worldwide, $27.8 billion in 2006 from statin drugs. Half of that went to Pfizer, the leading statin manufacturer of Lipitor. This was in Business Week 2008. These are the therapeutic effects that have been shown with statin drugs. They're quite impressive. They can lower the total cholesterol by up to 42%. That's a significant reduction. They can decrease the LDL cholesterol by 27 to 55%. That's a significant reduction. It has a modest effect on the HDL to LDL ratio. But the thing about statin drugs that I do like, I think they're overprescribed, just my view. But where they have application for my money is where the person's already had a vascular event. See, for the primary prevention of vascular disease, lifestyle management is outstandingly good. The person's already had a heart attack and they survived it. Then they've got more advanced problems. What you need is stabilization of the plaque. What happens sometimes in a heart attack is not that where the arteries are narrowed, the platelets can clump together and form a final plug. That's one way. The other way is that the plaque that's there can break off and float downstream and then clog up another area where there's some narrowing, and then that piece of plaque floating through the vascular system clogs up something that's downstream. And so the statin drugs, there's some evidence to show that they create what's called plaque stabilization. So plaque stabilization is quite an important effect to stop the plaque from breaking off and floating downstream and creating a vascular event somewhere else. So where the person's already had a vascular episode, I'm not against the person using a low-dose statin drug to stabilize the plaque. There are studies that they did with the Air Force in the United States with young men showed that over a 5-year period, roughly, that even with men that had mild to moderate high cholesterol, they were able to decrease heart attacks and major vascular heart attack events by 30% compared to the group not given statin drugs. So when doctors are shown that evidence from the drug rep or from a drug company, it's very impressive. It makes them want to take even young people your age, and say, oh, your cholesterol is just slightly elevated. You know what? Statin drug will decrease the chance of you having a heart attack by 30% over the next 5 years if you take it. If you don't take it, your risk is 30% higher. That's sort of what their thinking is. The problem in a study like that is that there was no third arm. The third arm of the study should be, how about we lower people's cholesterol with exercise and diet and maybe even supplementation and see if they get the same effects as the people who are on the drugs. Because there's no third arm to the study, there's no lifestyle arm that was done in that particular study. There have been studies where they used lifestyle interventions, it's been very successful. But because in those major studies they're just using drugs, they're going, the drug gives the effect, and not taking the drug puts you in a dangerous category. So we give drugs now even to young people. I think, that's overprescribing. That's abuse of the medication. So I want you to find this in the patients who are taking statin drugs where lifestyle change could actually bring the cholesterol into the ideal range. Maybe they can get off those drugs because there's risk of liver damage that's serious if they take it over a long enough period of time. That concerns me greatly. The dosages are 10, 20, 40, and up to 80 milligrams a day. Most health benefit plans pay for this. In fact, when you speak to the PR people, not the PR people, but the human resource people, the HR people in major corporations, as I do, they'll tell you that the single most important cost in their health benefits utilization package for their employees is not just drugs, it's this drug. That almost every single employee in their company who goes for a regular checkup from their family doctor is put onto a statin drug. Why? Because most people who have atrocious diets, as we have in North America, have a cholesterol level that's slightly above what's considered to be normal or optimal. So they're just automatically given a statin drug, or they're encouraged to take it. Because the doctor thinks, I'm reducing this person's risk of heart attack by 30%. And there's no lifestyle coaching that goes on. And the drug plans pay for it, and so drug costs and drug utilization and health benefits are skyrocketing out of control for companies. They're going, we don't know how to control these costs anymore in our employee pool. The next drugs are these bile acid sequestrants. Before we had statin drugs available, we had these bile acid sequestrant drugs that could actually bind to bile acids in the intestinal tract, drag it through, and the person, when they defecated, the bile would leave. The liver would have to clear more LDLs from the circulation, so blood cholesterol would go down because you keep dumping it through the bile duct into the intestinal tract, defecating it out of here. Every time the person has a bowel movement, more bile acids are leaving, more cholesterol gets cleared from the bloodstream, converted to bile, flushed through, next meal, you lose some more. So that's how bile acid sequestrant drugs work. They can lower cholesterol by 10 to 15%. Drugs like cholestyramine are a good example. But they also can inhibit the absorption of fat-soluble vitamins. They cause some bloating and GI upset. And because of the increased bile in the large intestines, some studies suggested they may increase risk of colon cancer, but that's still being debated. But as I talked to you about earlier, they got the idea to even make these drugs by looking at what soluble dietary fiber can already do naturally. So why don't you just give the person more fiber? I mean, it's just so obvious what to do. And we know the exact quantities, and we're going to look at that. Where the person has high triglyceride levels, and their cholesterol level is elevated or normal, but triglycerides are the bigger problem, then they're not given statin drugs per se or fibric acid derivatives. They're given what are called fibric acid derivatives. They're not given bile acid sequestrants or statin drugs, but rather they would be given fibric acid derivatives like fenofibrate, because they lower triglycerides, elevate the HDL, and also promote uric acid excretion. That's interesting. If the person has gout and you're trying to get more uric acid out of their body, the fenofibrate also would make sense in this instance. What does it do? It increases lipoprotein lipase activity. So if I increase the LPL activity, I clear more triglycerides out of the bloodstream and into the fat tissue, into the muscle cells, my triglycerides go down. You understand that? And I also raise my HDL. So if HDL is really low and triglycerides are high, fenofibrate becomes a drug of choice. I go, I can lower the triglycerides and raise the HDL if I use fenofibrate. It can lower triglycerides by up to 50%, has a modest effect on cholesterol reduction, and can raise the HDL by 10 to 15%. But I can't use a fenofibrate drug because it can damage the liver or the gallbladder. So if a person has liver or gallbladder disease, I can't use it. If they have kidney disease, I can't use it because it'll cause kidney damage. These drugs can be very toxic. So a lot of people who are sickly, what normally happens is person's overweight, out of shape, they're a pre-diabetic, they have high blood pressure, they got a fatty liver, the kidney function's failing. It's like, well, I'd love to use fenofibrate, but they got all these other complicating issues, so I can't use it that easy. I have to be very careful how I use it. Side effects, you see them here. Just the doctors would be on the lookout for these things. I wouldn't expect you to remember all of this for the sake of an exam. And then the final drug to manage hyperlipidemia is niacin. High doses of niacin, 1,000 to 3,000 milligrams. As a complementary practitioner who can't really follow people's blood work and do the monitoring necessary of liver enzymes, you're not in a position to recommend high doses of niacin to patients. You could damage their liver very seriously if you can't monitor for this. So even though niacin is a naturally occurring substance, you and I can't use it at these pharmacologic doses that we're going to talk about. But it's the most effective drug to lower triglycerides and also to raise HDL. Also has a mild effect on lowering the LDL. What's the mechanism? It inhibits hormone-sensitive lipase. Okay, so let's look at this before we lose concentration. In someone that has abdominal obesity, which you know is a more dangerous type of obesity for vascular disease and diabetes, you know that? As opposed to somebody that has more femoral obesity, that's more to gynoid obesity, where the fat is in the femoral fat cells. This abdominal obesity is more dangerous. Why is this? Because between meals, this is a more metabolically active fat. That means that between meals, the fat that was sent over to the fat cell in the very low density lipoprotein, and it got cleared by the LPL, the lipoprotein lipase, cleared it, and now the fat's in the fat cell. Between meals, the enzyme inside the fat cell called hormone-sensitive lipase gets turned on, hydrolyzes the fat. The fat now comes back out into the bloodstream. Now it's attached to albumin. It circulates back to the liver. The liver goes, what are you doing here? I just sent you to the fat cell, and now you came back. What are you doing? Now it has to repackage it into VLDL and send it back to the fat cell. And in doing so, it's going to raise cholesterol and triglyceride levels again. If I can inhibit hormone-sensitive lipase in the fat cell, then the fat doesn't circulate back to the liver, and my triglycerides stay lower. Does that make sense to you? That's what high-dose niacin is able to do that other drugs can't do. It may increase the lipoprotein lipase activity as well. From an unknown mechanism, HDLs under the effects of niacin can elevate as much as 35%. So a person who's overweight and not physically fit and who's a man who doesn't have estrogen, you're going to see very low HDL levels. So the way to raise the HDL is to get them into shape, get the body fat down, get them exercising. Doctors are trained. I give them high-dose niacin. It'll raise the HDL and bring the triglycerides down. They want to manipulate everything like it's a chemistry set. I'm saying, where's lifestyle modification in this story? But that's why they would prescribe a drug like niacin. They'll titrate it up to 1,000, they'll start 1,000 milligrams a day and sometimes titrate it up to 3,000 using a sort of a dosing system. And there's also a slow-release niacin where they can use lower doses and it gets released. But this niacin is tricky business. It can damage the liver. There's already pre-existing liver problems. You can't use it. Same with gallbladder disease. If the person has an active ulcer, it'll make the ulcer worse. It also induces glucose intolerance. So that fat person who's out of shape, who happens to be a diabetic or a pre-diabetic, now I give them high-dose niacin, I just made their diabetic condition worse. I just added to the glucose intolerance. So for diabetics, it's not appropriate. It also increases as you break down high doses of niacin, one of the end products is uric acid. You elevate uric acid, you give the person gout. So if they have any history of gout or hyperuricemia, they can't go on high-dose niacin. So, and even if they can, it requires periodic testing for liver function because it can cause liver damage. So even though niacin is naturally occurring, it's a B vitamin, it can be risky business to play with. So these are the precautions: liver damage. It can cause muscle damage as well. When you damage muscles, what you see in the bloodstream is a high dose of creatine kinase, right? CK is elevated in the bloodstream. So they look for elevated CK levels in the blood of people on these to see if there's any muscle damage being done. And of course, diabetics who have high triglycerides and low HDL, require glucose monitoring if they're placed on niacin therapy because it might aggravate the diabetic condition. So fibric acid derivatives are often a better choice for the diabetic patient, bringing their triglycerides down, raising their HDL without producing more insulin resistance. Not appropriate for a person with gout or ulcers.